So, dear friends, welcome to today's topic of graft rejection and failure. It is very important that all of us identify graft rejection, because early identification of graft rejection will help us reverse it and regain the patient's vision back. So, in the next few slides, we'll try to cover briefly about corneal transplantation, what the background is, what are the rejection rates, what is the terminology, how do you differentiate between a graft rejection and a graft failure, what are the predictors, causes and risk factors for graft rejection, what are the different types of graft rejection based on the anatomical level and also based on severity, and how patient education is important in the prognosis of graft rejection, what are the treatment options that are available to us, and what are the future trends that are being developed in this particular area. So in 2018 alone, if you see in USA, there were almost 85,000 corneal transplants that took place when compared to 30,000 that happen in India annually. So if you see, corneal transplant is the most commonly performed transplantation in the world, because the cornea has a relative immune privilege because of its avascularity and lesser expression of antigens. So these two things make the cornea more suitable tissue for transplant. However, if you see the Indian requirement to the number of people that are corneally blind, we almost need to perform 1 lakh transplants, but we are doing only 30. And when you see this scenario on a worldwide basis, only one patient is able to get a corneal transplant out of 70 which actually require them. So there are actually 70 people suffering with some form of corneal blindness, and imagine that in those 70, only one is able to get an access to a corneal transplant. So I think overall we need to increase the awareness about corneal donation so that they translate into transplantations for these people, those who need it. So coming to the rejection rates in India, if you see, if on a 5-year follow-up, 25% of all the transplants have at least one episode of rejection. And in this rejections, at least 40% of them, in this 25%, at least 40% of them end into graft failure. And the graft rejection rates, when you compare to a penetrating keratoplasty, are much lower and are usually below 10%. We'll discuss about these in the coming slides. So how do you differentiate between a graft rejection and graft failure? So graft rejection is a very specific immunological response of the host to the donor corneal tissue. So graft rejection should take place. It should have a process to have a graft rejection. You cannot just have it overnight. So your corneal graft after your transplantation should at least have clarity for 2 weeks, and only after 2 weeks it becomes to become opaque and you have signs of inflammation and signs of rejection, then only you can call it as a graft rejection. So immediate post-op period, within 2 weeks, it is very, very, very less likely that it's going to be a graft rejection. What you will get in the early period, I'll describe later. And a corneal graft that suffered from this immunological response or graft rejection, it may or may not fail. So it doesn't mean that if a graft is undergoing rejection, it has to fail. It can either fail or not fail, depending upon the time at which the patient presents to you and how effectively you try to reverse this rejection. So these two play an important role in reversing graft rejection and preventing graft failure. Now coming to the graft failure. Graft failure is what happens is when the graft graft does not retain any transparency sufficient for ambulatory or adequate vision, then you call it as a graft failure. So graft failure is usually a common endpoint that is arrived by different pathways. So in which there are three. One is primary graft failure. So primary graft failure is something because of a poor quality graft that is there primarily. Whatever graft you have got from the eye bank is probably having a very bad quality or very less cell density. So in that you can have primary graft failure. In this you can you never see the graft clear up. So you never see a clear graft in these cases. From day one, you see an opaque graft. So that is called as primary graft failure. That is the tissue you are getting from the eye bank, or sometimes even intraoperative manipulation, or sometimes endothelial damage can lead to this primary graft failure. Next, what we call it as secondary graft failure. The second entity is secondary graft failure. So this secondary graft failure is usually secondary to the graft rejection, which we have spoken earlier. Next, we have one more thing called as late graft failure. So late graft failure, typically you will not see any signs of rejection or inflammation. What happens is, suppose you have primarily taken a graft with cell density of 1700, 1500 or something. Over the years, the cell count slowly decreases, and once that cell count goes below the critical count of 500 or 400, this graft starts to fail. So this is called as the late graft failure. How do you differentiate a late graft failure and secondary graft failure? In secondary graft failure, there is definitely one or two episodes of rejection that precede it. Whereas in late graft failure, there is no graft rejection previously. It is only because of the decremental loss of the endothelial cells over a long period of time, and whenever that critical cell counts come down, then the graft starts to fail. So the above picture, what you are seeing is more of DM folds and edema. So this can be reversed by treating this patient, whereas here you see scarring, and there's almost a descemetocele also that's going to form here. So this is a classic picture of a failed graft, that you cannot regain the clarity in such grafts. So in any graft rejection, not only corneal, you have three elements. One is from the donor, two is how you react to it, and three is your body's antibodies that are producing. So let us see that. What happens is, whenever there is a donor cornea and when it is placed on the host, what happens is this antigen presenting cells go to the local lymph nodes or near lymphatic tissue, and from there they initiate and amplify an immune response. So this second process is called as host sensitization. So host sensitization is very important in the pathophysiology, because when we are speaking about this 2-week critical period in which you cannot tell that graft rejection will happen, because it takes at least 2 weeks for this host sensitization to happen. So before 2 weeks, it is less likely that you're going to get a graft rejection. And the final step is, once the host is sensitized, they'll start producing cytokines, and antibodies will travel back to the allograft site, and they'll start to exert their inflammatory and destructive response. So in any graft rejection, so you have to remember these three elements. One is antigens from the donor, host sensitization, and then host response in form of antibodies, helper T cells, cytokine, all these things, they go and start attacking the allograft. So coming to causes and risk factors. So if you see, if you ask me to tell the most important risk factor for any corneal transplant, first on my list would be vascularization. So if you are having vascularization on the host recipient bed, it is very, very more likely that the subsequent graft is going to fail. So avascular corneal beds are ideal. However, if you are having vascularization that is limited only to 1 or 2 quadrants, even that is good, but you will still have medium risk. But if the vascularization is in more than 2 quadrants, then it definitely has a very high risk. And then coming to different kinds of conditions for which you're going to transplant. So keratoconus, corneal dystrophies, a healed corneal skull after ulcer, or pseudophakic bullous keratopathy, all of them have moderate to excellent prognosis. Whereas corneal scar after an active ulcer, because this is what we are telling in a therapeutic keratoplasty, and corneal scar after trachoma or any ocular surface disorder like chemical burn, Steven Johnson, or Moran's ulcer, or a regraft, all this will carry a poor prognosis. And whenever you are especially dealing with ocular surface problems, it is advised not to do a corneal transplantation straight off. First, you have to stabilize the ocular surface, either with an amniotic membrane graft or a mucous membrane graft, or if the other eye is normal, you can do a simple limbal epithelial transplant. And then once you stabilize this ocular surface and make it less hot, less vascularized, then you can plan corneal transplantation as a secondary procedure in that cases. And so this is what we have described in the thing also. So in any case where you have a perforated ulcer where there is an angle breakdown, in that cases also the graft rejection will be high. Prior ocular surgeries for glaucoma or retina, and large grafts, especially grafts that are more than 9 mm, also tend to attract vascularization fast and also tend to give into graft rejection. And also the age of the host. Whenever the age of the host is lesser, it is more likely that he's going to give back a strong immune response. So as the host age increases, the transplantation for your graft rejection keeps on decreasing. So what is the role of tachymetry and specular microscopy in graft rejection? Both of them have a very good predictive value to know and see whether that a particular graft is going into a rejection and failure. So for example, pachymetry values and specular counts, it's ideal to take both of them in all the post-op visits, but the specular counts 6 months post-op is the most critical value. So after 6 months of a transplant, the endothelial cell count you have has a very, very strong predictive value on the graft survival rates. So first let us cover that. So if the specular counts are less than 1700, then your graft survival chance or graft rejection comes down by 12%. But if it is maintaining above 2000, it comes down by a very minimal of 2%. And after 5 years, the viable cell density should be maintained at least 500. And pachymetry values, if the values are somewhere between 500 and 550, the chances of failure are 5 to 7%. If they are between 551 and 600, they go up to 10%. Anything above 600, it is a warning sign, and it has 20% that this graft is going to fail because the edema. So always remember to note down the pachymetry in every follow-up visit in these patients. Whenever the pachymetry values are incrementally going up, suspect for corneal edema and look out for early signs of graft rejection or failure. And when the specular counts, the post-op 6th month specular count should be like a benchmark. So if you are having counts that are 2000, you need not worry. It is more likely that this graft is going to survive very well. But if this count is below 1700, you should follow up the case more frequently and have to look at it that the cell count is not deteriorating further. So then coming to types of rejection, it can be on the anatomical level, epithelial, stromal, endothelial, but usually these are not very differentiated. You can also have a mixed form. You can have an epithelial with stromal, you can have an endothelial with stromal. So it is not strictly separating, but you can, depending upon the clinical signs you see, you tend to see which type of rejection it is. And in the same way, depending upon the severity, you can differentiate it into two forms, the mild form and severe form. So in mild forms, these are more reversible kinds of rejection, where you have localized edema and less than 5 kps with minimal or no AC reaction at all. Whereas in severe forms, there is generalized edema throughout the graft, and there are definitely more than 5 kps. There is marked AC reaction, and also you can have endothelial rejection lines. So whenever the edema is localized and less kps with less than 5 kps with no reaction, when you promptly treat it, more likely that it is going to be reversed. But when you get it, have a generalized edema with more kps and all these things, so this kind of presentation may probably require a longer follow-up and longer treatment and more steroids in different forms. So that also will tell you which kind of rejection you are dealing with. So coming to epithelial rejection, the first form, again in epithelial rejections, you can have two kinds. One is the actual epithelial rejection that forms in form of a line. If you see in this picture, from 4 o'clock to 8 o'clock, there is a semicircle that is tenting up over the pupillary border. So this is the epithelial rejection line. It stains very well with fluorescein and rose bengal. It usually progresses over the cornea, and it also can form a ring. It can start off as a ring that can start in the periphery and slowly progress into the center. So this rejection line is nothing but the destruction of the donor epithelium that was transplanted. So this is not so much to be worried about, because your host epithelium will grow back, and to aid this, you can put the patient on a preservative-free lubricant ointment in the night. The second form of epithelial rejection is similar to what we have spoken yesterday, that is the subepithelial keratitis. So this is more of an immune response mechanism. It usually takes 2 to 3 weeks and it resolves spontaneously. So you can reduce this thing by increasing the steroid dosage. So in the early postoperative period, that is the initial 3 months, you are more likely to see this kind of epithelial rejections. So this, when you treat it properly with steroids, or most of the times they become self-limiting, you'll prevent it from progressing into a endothelial or more dangerous kind of rejection. So epithelial rejection, more likely that you're going to see it in the first 3 months. It will be self-limiting. And two forms that you have to remember are the epithelial form and the subepithelial form. Epithelial form is nothing but destruction of the donor epithelium. The host will grow back. Subepithelial is an immune response where you just have to increase the steroid dosage until these things go away. Next form is the stromal rejection. The stromal rejection happens very rarely in isolation. It is usually accompanied as part of the endothelial rejection. So the most important thing is there is full thickness haze of the entire tissue, and there is marked perilimbal injection around it. And sometimes you can see half circled or arc shaped infiltrates that advance from periphery to center in the stromal area. So these are all the signs of stromal rejection. Next, coming to the most important and dangerous kind of rejection is the endothelial rejection. Endothelial rejection again has two forms. One is the classical endothelial line or the Kudados line. It starts from the vascularized portion of the graft host junction. So always when you want to know where the Kudados line has started, look for the graft host junction 360 degrees. Wherever you see vascularization, it is more likely that it's going to start from that quadrant. And this line is nothing but a mononuclear white cells. And as they sweep across the endothelium, they'll destroy the endothelial cells that come in the way. And there can be some kind of AC reaction that could be moderate to mild. And the important thing in Kudados line is, as it progresses, whatever is there behind it, it will become opaque. Whatever it still didn't cross will remain clear. So that is how you can know that from here it started and it is going towards the direction in which the cornea is more clearer. And here I want to have a special mention about Professor Kudados, who passed away in 82 years in 2018. So Kudados lines were described by him not when he was a professor or some great ophthalmologist, he worked in the Wilmer Eye Institute at Johns Hopkins. So Kudados lines were described by him when he was a resident. So as a resident, he observed these lines in post-corneal transplant patients, and then he named these lines after him. So it is just to inspire the postgraduates who are listening. So when you have keen observation, it doesn't need you to be a professor or a researcher. So with keen observations, you can make a lot of contribution to science. So that's one interesting story I wanted to share about Professor Kudados. Next form of endothelial rejection is the more diffuse and scattered type of rejection, where you have lot of KPs and there is marked AC reaction when you compare to the endothelial rejection, and there is generalized stromal edema, and there is corneal injection. So this kind of endothelial rejection, whether it is an endothelial line or a diffuse, this definitely requires admission at least for 3 to 5 days, and you have to start the patient on a rigorous steroid therapy. So this therapy I'll describe in the later slides. And one important predictor is if you have the pre-op notes, and if you know that there is no stromal vascularization in this case previously, the outcomes are likely to be better when you compare to a case that has stromal vascularization in the host bed preoperatively. So that is one important thing where you can at least predict that this endothelial rejection is going to have a better outcome or not. And next, let us see the rejection rates in penetrating keratoplasty when you compare it to lamellar procedure. The line above is of PKP. So epithelial or subepithelial rejection amounts to less than 5% of total of rejections, and endothelial, as I was telling you, amounts to 50% of total rejections in PKP, whereas it can be in mixed form in 30%. When you take lamellar procedures like DAL, stromal rejection can happen in 20% of the cases. In DSEC, endothelial rejection can happen in 10%, and in DMEC, it can happen only in 5%. So you can see the clear reason why we are preferring more and more lamellar procedures when compared to a penetrating keratoplasty, because the rejection rates are drastically coming down in this lamellar procedures. So most important thing here again is patient education and prognosis. As I always keep mentioning to my fellows, doing a keratoplasty is only 50% of the job. Preparing the patient mentally for a corneal transplant and for a proper follow-up is the remaining 50%. So you should always educate the patient about the importance of a corneal graft, how much effort has gone into getting that graft, collecting that graft, processing it in an eye bank, and then putting the transplant on his body. So always make him educated to identify the early symptoms, like vision loss even for a couple of hours has to ring an alarm bell, pain, redness, and photophobia. So all these things, when he can identify early, we have higher chance of reversing it. So the reversal chance is somewhere between 50 to 90%, again depending upon the time and which the patient presents to you and how effectively you treat it. So, and final degree of damage is obviously depends upon the degree of irreversible damage that happens to the endothelium. So management is pretty simple. Put steroids in each and every form you get. So put him on steroids on an hourly basis. In night cover, you give him a steroid ointment. You can give subconjunctival injections. You can give systemic injections for the initial days and then maintain him on oral corticosteroids. But in all these things, you have to be careful to monitor the IOP and also rule out any diabetes and immunosuppression. So in these cases, usually maximum steroid therapy, most of them respond within 1 week. And once they respond and the rejection is cleared, then you can slowly taper them back to their original dosage of steroids. But if they are not responding to 1 week, it is ideal that we continue this maximal steroidal therapy at least for 2 weeks, do all the required tests, and again probably continue for 2 more weeks. So we should wait at least for 4 weeks before we call it a graft failure, not before that. And whenever there is a steroid responder or you have a problem with the diabetic where you can't give him systemic steroids, there is a very critical and important role for cyclosporin and tacrolimus in such cases. So, so these are all the different things that they have tried. I don't ask you to do it routinely, but these have been tried, like multi-quadrant subtenon triamcinolone. So this was again in a case that was not responding to maximal steroidal therapy. So what they have done was they have injected 0.05 to 0.1 ml triamcinolone in each quadrant, closely monitored the IOP, and then titrated the steroids. So in here, they were also giving steroid therapy along with subtenon triamcinolone. So here you can see the pictures of follow-up. This was the initial picture where you have diffuse edema, then the superior part, it slowly started clearing, then the whole graft started clearing. So maybe this kind of things you can reserve it as a last attempt before you call it a graft failure. And one more such kind of approach, interestingly, is the dexamethasone vitreal implant. This was a 0.7 mg intravitreal implant. And here, interestingly, they did not use any concomitant therapies because patient was a diabetic. So they only just put him on 0.7 mg intravitreal therapy, and according to the paper, they did not even put him on topical steroids. So within 3 months, this is how the graft has regained its clarity. So these are all single kind of case reports, so we have to take them with a pinch of salt. But I'm just telling you that these should be the last options when you try all the kinds of topical, subconjunctival, systemic, and other form of injections or IV methylprednisolone. All this is done and still there is no use. Then probably you can give this kind of approaches a try. So, and the role of immunosuppressants again has a paramount importance in graft rejection, especially in high-risk graft. So these 3 boxes, they correlate to the 3 causes that I have told you in the rejection factor. So let us go into that. So cyclosporin and tacrolimus, especially tacrolimus, has a very critical role in maintaining grafts, especially in steroid responders. And also what we have found in our experience is tacrolimus has a very positive effect in therapeutic grafts, especially fungal keratitis. You cannot start the patients on steroids postoperatively. In such cases, if you are putting the patient on tacrolimus eye ointment during night time or BD, and you can maintain the clarity of the graft at least for maybe one month or 1.5 months, and then you rule out any reinfection of fungus, then you can start the patient slowly on steroids and salvage the same graft for optical purposes. And in the same way, methotrexate is given for cases that have rheumatoid arthritis, PUK, ocular pemphigoid, and Moran's ulcer. So these are all peripheral patch grafts where the vascularization is more, and they obviously fall into the high-risk grafts. So here there is definitely a role for methotrexate, but you have to do it under an immunologist's advice. And azathioprine and mycophenolate are also can be used as adjuncts whenever you are not getting good results with steroid alone. And there is a lot of research that is going on with tacrolimus loaded nanoparticles that are injected into the AC, and those also maybe in high risk grafts can reduce the graft rejection rates. So finally, I think we'll just see some future trends like the role of in vivo confocal in diagnosis and how pre-treated corneal buttons can help us in the graft rejection area. These are just for your information. You need not take a serious note of them, but it's good to know that things are happening. So these are from 2 very famous institutes. One is from the Harvard's Mass Eye and Ear, and from the Bascom Palmer. So in this, both of them have tried to see the role for in vivo confocal microscopy. So according to the Harvard study, the immune cells that are seen in different layers, they correlate with signs and symptoms of rejection. So what they're telling is, if the immune cells are significantly increased in the subbasal and endothelial layers, so it is a sign for rejected cornea. In the same way, endothelial rejection, there is a generalized increase in immune cells, whereas the increase in immune cells in subbasal layer was associated with pain, irritation, and photophobia that we see as symptoms. So if you are seeing a subbasal layer increase in IC, that patient will be suffering from the symptoms that are most commonly we see the pain, irritation, and light sensitivity. So that is the mass eye and ear study about immune cells on in vivo confocal microscopy that you can see in the subbasal layer and endothelial layers. When coming to the Bascom-Palmer study, they have something different. What they have tried to do is they have tried to measure the endothelial DM complex, and then they try to correlate with the corneal thickness or pachymetry that we were talking in our previous slides. So the central endothelial DM thickness is called as DMT, whereas the DM endothelial DM rejection index is the DM thickness related to the entire cornea. So what they are telling is higher DMT and DRI values means whenever the endothelial DM complex thickness goes up, it is an excellent predictor for graft rejection, and it is better and happens more earlier than a central corneal thickness increase. So what they're telling is you can even start picking up graft rejection even before you start seeing increase in pachymetry, because they're going to take these values at the root cause, that is the endothelial DM complex. And not only that, the DMT is also quantitatively correlates with the severity of rejection. The more DMT the value has, it means the more severe the rejection episode was. So I think that is one of the interesting research that's going on in these two institutes. And finally, one more thing is, and especially when you are treating with high risk grafts, you can treat the corneal grafts with recombinant interleukin and transforming growth factor beta. So when they have done this studies, preclinical studies in rats, the survival rates in such cases was increased by 70% when compared to controls. So I think this is one promising area where you know that if you're going to do a high risk graft, you can probably use a pre-treated corneal tissue so that the rejection rates and survival rates will increase and your rejection rates will come down. So thank you all for your time. Now I'll unmute all of you. You can ask questions.